can everybody see the röntgenogram?
Yep.
All right, so apropos of cases that Travis brought up last week with recall pneumonitis. So this is a slightly unusual situation of, but very dramatic recall pneumonitis. This fellow had a lymphoblastic lymphoma and about a year ago or more had mediastinal radiation. So this is the point now where he has now, a year or more after radiation has had a stem cell transplant. And I don't know what his conditioning regimen was before the transplant, but at this point he has nice clear lungs and a pretty good looking mediastinum. So that is early in May. He was receiving methotrexate intrathecally, and on this day, he received his intrathecal methotrexate. And it's been shown that this does leak out into the body, so if there's a circulating component that could be measured, but I don't know whether that was done in him. And then this is now a couple of weeks later, so this is the beginning of May in 2004. Here is recall pneumonitis surrounding the mediastinum, pretty dramatic here. 3 weeks later, so he'd had a stem cell transplant a couple months before this, and he was getting intrathecal methotrexate. I don't think he was getting any other chemotherapy. But at this point, he's got this dramatic recall pneumonitis. He was treated with prednisone, and a couple of weeks later, here you can see 614. This a few weeks later, you can see that it's melting away to some degree here, a few weeks after the therapy. And then this is a conventional view, 614. And this is a very dramatic case of recall pneumonitis. Now, I don't know whether it's the stem cell transplantation that set him up for this, or the leaking methotrexate, or perhaps his conditioning regimen from the stem cell transplant about 2 months before this set of radiographs. So if you see this pattern here on imaging, do you guys agree that this is radiation, looks like radiation pneumonitis?
Yeah.
Indulge me. Okay, and here's what it looks like.
That's fantastic. Yeah, how far out was he from the radiation?
More than a year.
Okay.
So do you agree this looks like radiation pneumonitis?
Yes,
definitely.
Very straight.
Okay. All right.
I wonder if it was the stem cells. I don't think a methotrexate causing,
right.
It causes, more typically it's a more chronic lung injury. But you can imagine you have prime tissue, and then and I take it was an allogeneic transplant, so it was someone else's cells.
Right.
So that might, I've never seen it that way, but I think that may be a good explanation.
Okay. I was just wondering whether it might have been, I don't know what chemotherapy got before radiation, so I'll have to check that. And maybe there was something there that was more radiomimetic, because they talk about this occurring with the radiomimetic kinds of chemotherapy. So I'll see if he got beam or something like that before his transplant. Okay, and then I wanted to show you guys some cases of nodules. So here is also a chemotherapy patient who had a bunch of small lung nodules like this show up. And this grew out, and I think, I wish I had some MIPS, but they don't seem to have come up here. I guess I could generate some MIPS from this. Let's see if that helps to bring out these nodules here. So, yes, I think it does. So you can see he's got a ton of small lung nodules here. And they seem to be pretty much everywhere. A lot of them are really right against the periphery, suggesting that this might be a miliary blood-borne, a random distribution here. And indeed, this was fungemia, and his organism cultured out of his blood was Candida tropicalis. So if you see a lot of small lung nodules, then it's probably not aspergillus. And Candida, I've seen several cases of Candida that had lots of lung nodules. Another place to look for these lesions is in the spleen, see if there are low attenuation spleen lesions a la Candida, and the answer is no, I'm not seeing them here. So Candida tropicalis, a blood-borne hematologic dissemination to lungs here. Okay, so nodule 1. And this is nodule 2, a woman who has lots of bad habits, mostly cigarette smoking. And she's got some larger nodules, and they seem to be in an airways distribution, and they're mostly in upper lungs, but she does have some in the bases. These are not particularly peripheral, a la septic emboli, a la bloodborne infection. It seems to be more of a peri-airways upper lung distribution. And besides her cigarette smoking, she smokes marijuana every day, and she cultured aspergillus out of her lavage. So this is presumably marijuana derived aspergillus bronchitis, given the distribution of these nodules, the fact that they go to airways, that they're upper lung predominant. This fits with other cases of marijuana dissemination of aspergillus into the airways. So aspergillus contaminates marijuana smoke in some people, and I think this marijuana is a great aspergillus delivery system. So aspergillus from bad habits.
Nice.
Yes.
I wonder if we're going to see more of that.
Well, it's legal, and some people interpret that illegal as being the state encourages it. So they do make some tax revenue on it. So I think we should, tell people that they can help their state. Let's just see how it looks here on coronal. Again, the upper lung predominant airways distribution here of aspergillus.
It almost looks a little LCH-like, doesn't it?
Yeah, and with her cigarette smoking and stuff like that, except that the nodules are a little more irregular than you see with a lot of LCH.
Yeah,
so.
it's nice though. It shows the same distribution.
Right. Okay, those are my 3 cases.
Thank you, David. And I see Howard is on. So either Travis or Howard, if either of you wants to go next.
I'm ready with some.
All right.
Okay, do you see a CT scan?
Good.
All right, actually, this is the one I want to show you. So this is a phenomenon we've seen before, and one not to be mistaken for anything sinister, but it was mistaken in this example. It's a slightly different distribution and variant of what we've seen. So this is a patient with pancreatic cancer. You can see in their lower thoracic vertebral bodies that they have these sclerotic-looking foci, multiple levels. There are a few clues here as to what this might be, as they're in several contiguous levels. And of course, you can also see that there are some vessels that are brightly opacified here. Let me stop this sync. So this was the prior study from a couple years ago. This was the most recent follow-up they had. So these findings were all new. And that was the only finding they saw. And of course, this raised the possibility of sclerotic bone metastases. And so this was brought to my attention when they did the PET 2 days ago. And you will see, unsurprisingly, that this is a non-contrast PET. And lo and behold, all of these sclerotic appearing foci in the lower thoracic spine are gone. And of course, nothing happened in the interim except that they didn't give contrast. And so, as we've seen before and was published, I know I've shown at least a case, and I think others have too, this is venous enhancement mimicking sclerotic metastases. And I think the big clue here is the fact that you have all of these collaterals, including the azygos system and these chest wall collaterals. And so, of course, that begs the question then, why does the patient have all of these collaterals? And we'll get to that in a second. But you can see 5 or 6 contiguous levels here. And if you're not attuned to this, then it's easy to say that these look like sclerotic metastases. But in this case, the patient had an indwelling catheter, and we can see that there was some catheter associated thrombus. And let me go back to it. And the SVC gets pretty darn narrow right in here. So it's either focally occluded or it's just narrowed. And so now that you have SVC syndrome brewing, this is why there are all those collaterals into the chest wall. So this is the first time I've seen it so profoundly affect the lower thoracic spine. Usually we think of it affecting the upper thoracic spine and lower cervical spine, I think, because usually you get more collaterals to the neck. But I thought this was a good time to revisit, this phenomenon, just because we've seen it. And this was the paper from AJR a couple years ago where they show, the same thing, just that you have these venous plexi that cause the contrast to enhance in the bones and mimic these sclerotic metastases. So have you guys seen it this low in the thoracic spine before?
No, not that I remember. That's a very nice example.
Yeah.
Nope.
Yeah, and of course.
How about the liver? Any collateralization via the vein of Sappi with
Is that the hot? Is that what gives you the hot quadrate?
right?
Mm-hmm.
Yeah. No, there's some return into the IVC here. I'll go back to the axial. But no, there wasn't really a lot. You can just see it going back directly into the IVC right there. So, but pretty good example of this potential pitfall. Okay, let's see. This is an interesting case. And this is a patient who is a Cantonese speaking man who immigrated to California 3 years ago and had weight loss, some subjective fevers, chills, etc. over the course of a couple months, went to an outside hospital and got this radiograph. And I'll let you look at it for a second. You can see that there's considerable amount of right paratracheal widening right here, and there's some adjacent abnormality in the right upper lobe, and some of it even looks more chronic, like he's just got scar maybe from prior pneumonia. Now, he actually came in, his most pressing symptom was that he had this mass in his chest wall, and you can see right here that he has looks like the sternal head of the sternocleidomastoid. There's this rim enhancing or low attenuation thing that extends along the muscle belly and then invades into the sternum or erodes into the sternum here. And when you look down further, you see that he has these centrally necrotic right paratracheal lymph nodes, and they're actually contiguous with this stuff in his right upper lobe. And he's got some underlying emphysema. Clearly looks like he's a smoker. Now, what's interesting is at the same time or shortly thereafter, he was having neck pain, and they did this neck CT. And I don't know why it wants to keep syncing these. This C-spine CT, and this is rather impressive. You'll see that his C2 vertebral body is nearly completely just eaten through here. Even C1, the dens, you see that. And he had several other lytic lesions throughout his spine, including in his abdominal, in his lumbar spine and in his pelvis. And so this was originally thought to be metastatic cancer of presumably right upper lobe origin, given the appearance of what was thought to be maybe a mass directly invading into the mediastinum here. But when I went digging, because I know this question will come up based on the answer, turns out he moved from Asia to the Central Valley and has lived in the Central Valley for the last 3 years. And when they did an FNA of the sternum, and it was all Coxy.
Oui.
So this is all a disseminated coccidioidomycosis, not cancer.
Wow. I thought it was going to be TB.
Yeah, I know that. Yeah, exactly. But this all turned out to be Coxy.
It's amazing.
So just a reminder that infections can, mimic cancer or look similar to cancer in a lot of cases. So, or in some cases like this.
Not only that, but in this immigrant population, we've seen a few cases of what was thought to be TB with lung and bone disease, and it's Coxy. So you really have to keep Coxy in mind. Yeah.
And here, this was you can see in his pelvis, he had a few of these lesions too, that they, here, left iliac crest right there, maybe right half of the sacrum too. So do you see Coxy a lot in Washington, David, or are they patients that are coming up from California or from Arizona?
People move around. So we've seen a
Yep.
couple of Mexican patients. We had one referred from a salmon cannery in Alaska, a Mexican man who's thought to have TB, and he had Coxy. It turns out that he spent part of the year in the salmon cannery, but he spent other parts of the year picking, fruit in the Central Valley, and he moved through from California into Oregon and Washington following crops, and then ended up in Alaska too. So people move around. We now have Coxy in eastern Washington. It's established. It's endemic in the dry, sandy areas of eastern Washington. So yeah, we have our own Coxy, but we have a lot of Coxy that people have brought from the Central Valley and Arizona. We also have people who take vacations. So we have transplant patients who get Coxy because they spend part of their time in Scottsdale, Arizona, part of the year.
Right.
So we see Coxy, yes. And you even get it in San Francisco when under these Santa Ana wind conditions. You can get it, a rise in people in San Francisco who've not been to the valley.
Right.
The valley comes to them when the air moves from the east.
Wow.
Yeah, Coxy's no laughing matter. So this is one, I kind of wish Seth was on here because I remember the last time I showed one of these that he had a question about it. But this is probably the third or fourth one of these that I've seen. And now that many of us have seen these, we don't get fooled by this anymore. But this one has a really pretty interesting appearance. So this is a patient that has a left ventricular assist device. He's had it for several years. And he presented with a relatively abrupt, like over the last couple of weeks, like recent low flow alarms, meaning that there's some suspected thrombus or obstruction somewhere. And as I show you, you will see pay attention to his outflow cannula, and you'll see that the lumen collapses. And this is really interesting because it has this little star or propeller shape to it. And of course, I've shown cases before where it wasn't thrombus, but it was fluid lining or in between the outflow cannula and this Gore-Tex lining. So in between the two lumens here. And so I think in this case, given this appearance, especially, I was convinced this was just more of that same fluid rather than thrombus, because thrombus, shouldn't look like that. And it looks like it has this mass effect. Because I remember the last one I showed Seth was asking, how do you know it's not thrombus? And sometimes I think it's just because it, looks like it's just more eccentric and external exerting mass effect. But I've never seen one that actually looked like this with this little propeller shape. But certainly thrombus shouldn't look like that. And I do have his report. I just need to open it here really quick because I saved it. He went to the OR, I think yesterday. And so and you can see here when they opened up this Gore-Tex tube.
This is Albert Shaw from UCSD over at Seth's side over here. We sometimes see that in the LVAD devices. If you do a 3D recon, you can see whether or not there's any twisting. I'm only getting like 2 or 3 frames, but you can sometimes see a twisted graft within this plastic shell, and that can be something that they have to deal with.
So twisting, or is it from mass effect from this fluid that accumulates in there?
I don't know.
They can hear you yet. They asked if it's twisting or if it's just mass effect from the fluid that accumulates.
No, it's twisting, and then there's just fluid outside of the graft material naturally that fills that space.
Right, because in this case, it was relatively like recent accumulation of this fluid. So they said a lot of it had accumulated there. With these HeartMate 2s, originally the problem was that they had the abnormal detachment of the bend relief, which this one didn't have. And I don't know if that's what some of the cases you had, because that predisposed to the like kinking of the outflow tract. But this one, the bend relief wasn't abnormally disconnected. It was intact, but it was still, just this fluid collecting in that area. Oops. So that was, so that's, we've seen a few of these now. I've shown several, and that's actually not the only one we've had in the past week. So let me find the other one. I don't know what happened to it now. Let's see. But that one was one that it's important to consider, because obviously if they do anticoagulation, it's not really going to impact it, because it's fluid outside of the outflow cannula. Here's the other one we saw last week, and this is the same thing. And you can see that there's extreme narrowing of the outflow cannula by this, presumably in this case, this is again fluid debris in the lining. And this one was done because this one actually has an additional finding too, which is that this patient, let's see, which one's the old study? This is the study from January. And the patient, you can see, had this narrowing that wasn't as severe. But the new finding on this, they had come in septic and had pus draining out along the drive line. And I think that there's a little bit of new inflammation surrounding the outflow cannula and in the anterior mediastinum that you can see, especially there's a little bit here. We'll see that's increased. And then as you go up along the outflow cannula, there's new soft tissue attenuation outside here in this region, you can see there and here. So presumably there's an infection that's extended deep from the drive line into the anterior mediastinum in this case, in addition to the fact that the outflow cannula lumen is narrower. But surprisingly in this one, and maybe to the point that's just made, that I guess conceivably this could be more dynamic, and this acquired during diastole perhaps, because this patient doesn't really have low flow alarms and has been similar, they've been similar function for months, and even the distal anastomosis looks a little narrowed. But patient had Klebsiella bacteremia, and presumably they're treating this as it's all presumably infected.
So your current patient had Klebsiella, or the old patient?
This one, yes. No, this current one. The one where the finding was isolated to the outflow cannula did not have any signs of infection. It was just low flow alarms. And once they relieved or drained that fluid from the lining, the flow improved immediately.
So they only drained the fluid. They didn't try to figure out where the fluid was coming from. Maybe there was some sort of a leak or something like that.
Yeah, I mean, that's a good question. I think that question has come up before, and I've never been able to come up with an answer. If it's, I don't know. If it's some sort of, if it just, I don't know. Yeah, there's got to be some sort of leak, you'd assume, to get something in there, or there are cells in there creating an immune response that causes the fluid to accumulate. But again, something has to be getting in there. So I don't know. All right, and then let's see. I'm curious what you guys think about this case. So this is a recent case from just a couple days ago, and this patient came in with this chest radiograph, and you can see that there's whiteout on the left with mediastinal shift to the right. And he had several weeks of just gradually worsening dyspnea and had noticed some voice change as well, but wasn't really acutely symptomatic at this point in terms of acutely deteriorating. So he went to CT, not surprisingly, and you'll see his left lung is collapsed, and he has a huge pleural effusion on this side. And in fact, you can see there's a small fluid level here. And when they eventually drained this, a lot of this was old blood in this case. But what is interesting is I'll show you these in succession, that they did a thoracentesis in the emergency department and took about 2 liters out of this. And he almost immediately started to deteriorate after that. And you can see this is a couple hours later. The lung has kind of reopacified, and I don't know if this is atelectasis or some reaccumulation of fluid. But if you look a couple radiographs later, and this is just several hours later, he now has a chest tube. This left lung has re-expanded some, but it's completely consolidated. And now there's new consolidation on the right lung as well. And then here you can see air bronchograms in this lung. And the patient died a couple hours after this, and it wasn't from exsanguination because there wasn't fluid that was still draining out of here. And so my question is, do you think this is just an actual severe case of re-expansion edema? Because that's what my best guess is in terms of what happened. Because of course it can lead to it's been reported to lead to death in rare cases, and I think that might be one of them. They're still not sure what happened, but they withdrew care, and he passed away a couple hours later.
It doesn't look like they took off very much after the first thoracentesis or the.
Well, you know,
they took off 2 liters.
Yeah,
here.
so it's deceptive because the mediastinum was so shifted to the other side originally. Not that the mediastinum was moved back.
Yeah, I guess so.
You know, you don't appreciate how much fluid they took out.
Right.
I mean, it was a huge effusion before.
Right, and then when he started to decompensate after this, then they put in the chest tube and took the rest of it out. By that time, he had new airspace opacities on the other side. There was no indication that he aspirated. I mean, my best guess is that this is probably acute re-expansion edema that was so severe that it actually caused, or precipitated his demise in this case.
I think that fits.
Especially because, since we usually see re-expansion edema when it's more of a chronic collapse of the lung anyway, and clearly this fluid just didn't, it wasn't all acute blood. Some of it was old blood, but not, it wasn't frank hemothorax. So this lung is presumably had been collapsed for some time.
What's strange about re-expansion lung edema is that one can find case reports of the contralateral lung also becoming edematous. So it's a very strange phenomenon. And I think one can find case reports of severe contralateral lung edema. Maybe this
like
is
this.
Yeah, like this.
Yeah,
I think this is a beautiful example of that, of the whole thing. So what happens is you have lung injury when you re-expand the lung. That's a systemic disease, and you're getting ARDS on the other side. So you've released a whole bunch of cytokines from that damaged lung on the left, and they are circulating, and they're now affecting the other lung as well. So I think this fits beautifully.
Yeah, okay, that was my best guess, and I don't know if they're going to do an autopsy or not. Probably not, but yeah, I mean, we see cases of more localized re-expansion edema after chest tube placement, but this is definitely the most flagrant case I've seen, and the only one I know of that's really precipitated a severe clinical decline. And
the course is classic in that initially that left lung cleared up, and then it reopacified within a few hours. Mm-hmm. So that phenomenon really fits beautifully.
Okay. Well, thank you for the input there. Jeff, I'm gonna stop here, and I've got a couple more if there's time at the end, but I know you and Howard probably have stuff.
All right. Howard, you ready?
Okay. I think I'm having maybe some connection problems. So if I fade out, it may be on my side, and let me know. But right now, can you hear me okay? And can you see my screen?
Yes.
Okay.
Yep.
So here's a very interesting clinical case. I'll show you in a moment a bit more of the history. But as best I can tell, the initial presentation of this young person was neurologic, or she had some set of neurological symptoms. I think headaches was part of it. And her initial imaging of her brain, or at least the MRI that was obtained, I don't know what else was, showed a pineal abnormality. So we have a pineal pathology. And then I'll show you studies in July. And I will show you now a radiograph from October, in which there are some ill-defined subsegmental sized opacities in the lungs. A little bit difficult to see in this radiograph, but the one obtained in December, which I'll put up next, is substantially abnormal. Now we have bilateral multilobar, poorly marginated, non-segmental opacities in both lungs. And I'll now show you what the CT looks like. So that's in October the 9th. Here is the 20th, 24th. And the 5 millimeters will suffice because we have these large, sorry, I went back too far. Sorry. is from the outside. So this is what I want to show you. Multifocal, large opacities. Some of them contain air bronchograms, so some airways can traverse these opacities quite easily. Some have very well-defined margins, other slightly more well-defined margins. So now we have a very extensive pulmonary parenchymal process in addition to the history of a pineal lesion. And let me just remind myself whether she has any lymph node enlargement. Well, yes, she does. It's modest, but these intrapulmonary lymph nodes are a little bit enlarged. So a very dramatic pulmonary parenchymal abnormality developed. So now let me bring up alongside the history. So you can see there the surgical procedure that was done, and you can see one report and then a consultation report on the brain lesion. And you can see a description of, certainly in the deeper sections here, the edge of a granuloma. And let me see if there's a description of some necrosis right there. So take a look at that. So we have some granulomas. Then we had a room consult and they considered GPA, but there were no findings of that. There was no kidney disease, nothing to support the diagnosis of GPA. Then you can see the lung biopsy result. Now we have granulomas, but we have some necrotizing granulomas and no organisms were found. So they made a diagnosis of a necrotizing process, but because of the granulomas and the involvement of both the CNS and the lung particularly, she was diagnosed with most likely so-called necrotizing sarcoidosis. And she was started on steroid therapy, and you can see that in January that her lung disease is a whole lot better. So based on those pathologic findings, I think this is consistent with a case of necrotizing sarcoidosis. Here's one article about necrotizing sarcoidosis. I'll just bring that up just to show you the sort of conclusion. But I think this particular pathologist says that necrosis is not that uncommon. And he says we shouldn't make some kind of rigid distinction between non-necrotizing nodular sarcoidosis and necrotizing sarcoidosis. And he simply says we should talk about sarcoidosis with necrotizing sarcoid granulomatosis pattern. So that's the diagnosis that this young person has. We think this is sarcoidosis with a very interesting presentation, but much better and doing well right now. Any thoughts? Any reason to be skeptical otherwise?
No, I think it's reasonable. And, you know, the cases I've seen of what were called necrotizing sarcoid granulomatosis have looked like this with these large masses and sort of these smaller nodules around it.
Yep.
And they do very well typically. They tend to respond and not have a lot of problems. One question I had, well, one thing that is interesting is, you know, you showed that article. I've read a little bit about this, and that there's a lot of controversy over whether it's a separate entity or not. And I like the article you showed because it sort of talks about it really being sort of a continuum or a spectrum of sarcoid and not truly a separate process.
Yeah.
Howard?
Yes.
You know, with the airspace pattern of sarcoid here, you know, when I was at Duke, that was mostly seen in Black people. Do you know what the ethnic origin of this person was?
No, I don't. I don't recall. Don't know.
So you had often very dramatic chest radiographic findings of these big, you know, ill-defined nodules in the lungs like this. And yet they, you know, and the other thing is they were usually not that symptomatic. So it's kind of the low end of symptoms, but the high end of radiographic abnormality.
Yeah, I got the feeling reading the clinical notes that that's probably the case here too. Yeah, that this was in part quite a surprise, a lot of like this. Yes. Very interesting. Okay, let me show you this case. I don't have a biopsy here, but I think this is going to be, I think you'll agree with me, this is a very nice demonstration of on CT, which I'll show you next, of many findings that one can see in a smoker's lung. So here's the chest radiograph, and other than perhaps perceiving that the pulmonary vessels here are a little bit attenuated, suggesting cystic disease or emphysema, and then maybe a very subtle background reticulation or reticular nodular opacities, that radiograph doesn't look quite impressive at all. So here I'll show you the thin cuts from the CT that was done the next month, and there's just a plethora of findings consistent with smoker's lung. I showed a case like this a couple of weeks ago, but just look at how dramatic and how, I think, easily one can diagnose smoker's lung. There's tremendous cystic disease. I like to think that some of these cystic exposures are so irregular that they're areas of Langerhans cell histiocytosis-related cystic disease, and then the lungs get very gray. Undoubtedly, there is a very heavy burden of smokers' macrophages in the lungs. Of course, that extends to the lower lung zones, the little cystic spaces here, but just, I think, a very nice example of all the findings one gets in smoker's lung.
That's nice.
Yeah,
Is there
pretty
any
dramatic.
fibrosis at the bases?
Let's go right down there. They actually look okay, other than the ground glass attenuation, which I attribute to the smoker's macrophages. We've seen cases before with so-called DIP, where you get these small, well-circumscribed cystic spaces, like that guy, for example. Yeah. We've seen that on occasion. Sometimes there are quite a few of them, sometimes just a few, like that.
So with all those macrophages, Howard, do you want to invoke DIP in that left base?
Yeah, sure.
Yeah. Ground glass?
You know, because of that sort of confusion with the DIP, I just say smoker's macrophages, but exactly that, yes. Yeah, but very extensive.
Oh.
Everywhere. A little heterogeneous, but just very, very gray lungs everywhere. Okay, let me show you the last one I have, which is actually just another nice example of something we see quite commonly. So I'm going to put up the frontal and lateral projection of the chest, tell you it's a young person, and particularly for trainees, you may be watching the video. Take a look at that and see what you see. And pay particular attention to the lateral projection of the chest. It's kind of easy to go by the pathology, so I'll show you that on this. And that shouldn't happen, so let me try and fix that for you. So look down here in the left lower lobe, which is right down here. We have quite extensive opacity in that portion of the lung. And now I'll bring up the axial, and I'll just go quickly down there just to show you what the opacities look like. It's focal, confluent opacities. Notice they don't enhance. More focal here, but what's kind of interesting about this, and we've shown cases before, is that there's a strange pattern of disordered aeration we see in here, and very typical of the opacities one will get with pulmonary embolism. And sure enough, there are the emboli. There's a small left pleural effusion. So a very nice example of focal opacity, certainly consistent with pulmonary hemorrhage. I don't know, of course, how much true infarction may be present there. I don't know what this is going to look like a couple months from now. If one imaged the patient, one would think this would go away. Maybe a small infarct would remain. But I thought I would show this because it's such a nice example of acute pulmonary embolism in a young person. I'm not quite sure why he has that, but just a terrific example of that. Easy to go by on the lateral projection. It's all just right in there.
Yeah, very nice example.
Right, those are my cases.
All right, thank you, Howard. Okay. All right, let's start with the first case. All right, you should see a radiograph. Let's start with the old one, though. So this is a 23-year-old, otherwise healthy man. He does have a history of Crohn's disease that's been well controlled with Humira, and he developed community-acquired infection or fever, cough, and had this chest radiograph back in the fall. And you can see there's a bunch of nodules on his radiograph, and for that he received some treatment. And this was him a couple of weeks later, and you can see he got better. Put them up side by side. So there was some radiographic improvement following standard treatment for community-acquired infection. But then his symptoms worsened again, so he had another radiograph a couple of months later. And although the nodules had improved, let's see, yeah, you can see that. There's sort of becoming a more confluent area of consolidation in the left lower lobe. So he was treated again for community-acquired infection, and it wasn't until, let's see, and then he showed back up again recently with this radiograph, and you can see that area of confluence in the left lower lobe is now a thick-walled cavity. There's some nodules around it, and there's a fluid level in it. Here's the lateral projection. You can see it. There's clearly some disease back in there. And then he underwent a CT scan, and you can see there's actually tiny little nodules in the upper zones, and then more clusters of nodules in the left upper lobe, and then this cavity in the left lower lobe with lots of airway-centered nodules and peribronchial consolidation. And this ended up growing out Mycobacterium tuberculosis, had a little lymphadenopathy here additionally. So, no risk factors for TB other than being on a TNF alpha inhibitor, but, no exposures. Unfortunately, of course, this, it's, who knows how long this was going on, but presumably for several months. And interesting, it sort of transformed from what we think of as a sort of a primary TB with consolidation nodules to a post-primary cavitary form. And his cavity is pretty low down too, which is also very atypical for Mycobacterium tuberculosis. So that's a little odd too. I think that's what may have thrown a lot of people off, is the cavity was in the sort of the wrong place. But yeah, TB.
Wow.
Yeah. So even in, it's, even outside the typical, socioeconomic class, travel history, etc. His only potential risk factor is he travels for work and had been in a part of southern United States near the Mexico border, but who knows where you could pick it up.
But he was a TNF inhibitor.
Yeah, so that's his immune suppression. Here's another sort of unexpected infection case. So this is a 73-year-old woman. She has a history of metastatic small cell lung carcinoma. She's been treated with chemotherapy, radiation therapy, has known brain disease, and for that received whole brain radiation.
Yes, at the moment, I don't see the images that you're showing unless my connection is bad.
No, it's GoToMeeting misbehaving. There you go. All right, so yes, but the story hasn't changed. So she has brain mets, received whole brain radiation, chemotherapy to her for the systemic disease, and she's on steroids for her brain metastases to reduce swelling. And she developed a cough, and this was her initial chest radiograph at that time. And she was treated for a community-acquired bacterial pneumonia based on sort of abnormal findings. Here she is a few days later, clearly not getting better. We see more conspicuous sort of nodules, consolidation in both upper lobes. And then subsequently had another radiograph a little bit later, and you can see it's still there, not getting better. And so she underwent a bronchoscopy, CT. Here's the CT at the time. And the CT sort of pushed us towards a different type of process here. You can see it's predominantly ground glass. There's spared lobules. It's very peribronchial, perilobular thickening. So it looks like an organizing pneumonia pattern. There's her treated small cell part of it. But she hadn't had recent chemotherapy. So at this point, we started to think about infection. So the one you'd think about, of course, would be pneumocystis that can present with upper lobe predominant ground glass opacity. In this case, has some lines mixed into it as well, and sort of has an OP appearance in a lot of cases here. And sure enough, the PCR came back for pneumocystis. So this is pneumocystis infection, and it has gotten better with treatment. So they're not always HIV, leukemia, but just purely high-dose steroids for brain metastases.
Yep.
Two unexpected infections, at least.
Well, yeah, people usually use dexamethasone for that brain swelling. It's a very potent corticosteroid, and so people just aren't thinking of that. You know, they don't put that in the same category as the person being on high doses of prednisone,
right,
in terms of pneumocystis.
Okay, this next case is a 63-year-old man who developed airway symptoms, sort of cough, wheeze, shortness of breath, and this was his chest radiograph. And maybe on initial look, he doesn't take a huge breath in, doesn't look too abnormal, maybe the little bit of indistinctness around the hyla, but as we know, that's quite subjective. But the lateral radiograph is very abnormal. There's thickening of the posterior stem line or posterior wall of the bronchus intermedius, which would suggest some lymphadenopathy, and it's just sort of, again, indistinct around there. But going back to the frontal, you don't see anything that really is not quite dense enough, but I think reasonable thought. So he has a CT scan, and the CT scan is quite striking. Let me blow it up a little bit for you. You'll see there's quite extensive bronchial wall thickening. I mean, to the point where the lumens are almost obliterated in some areas, but a lot of soft tissue thickening. And it's pretty diffuse, and it's bilateral, and has this very shaggy appearance to it. On both sides, narrowing of the main bronchi as well. Their walls are a little bit thick. So sort of a diffuse bronchitis-like pattern, but it goes beyond just the mucosa, but it looks like even the peribronchial lung all the way down. And then the bases is not as severe. So it makes you wonder, a couple of things you might think about, very odd sarcoid, but usually sarcoid's more nodular, and his symptoms were a little too acute for sarcoid. Other thing, in the right patient, we don't see it much anymore, but Kaposi sarcoma can give you this really shaggy look to the airways as the cells infiltrate along the lymphatics. And then what he has, which is a vasculitis that can predominantly affect the airways. And so his anti-proteinase 3 was elevated. He did have some kidney involvement. So this is granulomatosis with polyangiitis, or GP.
Wow.
And, this is a very uncommon manifestation. I mean, I've seen a lot in my career, but I've only seen this type of presentation just a handful of times where they have this striking diffuse airway involvement. More often you're going to see disease limited to the trachea, or, maybe subglottic. His trachea actually looks really good. And his trachea was spared as far as what we can tell. There's a lot of lymph nodes in the mediastinum that are visible, but that's not a typical finding of GP. I think it just goes along with the edematous airways and the inflammation. But look at the posterior wall of the bronchus intermedius, and that correlates nicely with the lateral radiograph. I'll make a sagittal here, and we can do a RASUM to kind of show that. And let's see here. But makes for a nice example of that there. You can see back in here some thickening there. So it's not always lymphadenopathy. In this case, it's truly bronchial wall thickening.
Amazing.
Yeah, that was a cool case. All right, these last two are pretty quick. Let me switch it over here. Hold on, you'll see. Okay, you should see a frontal radiograph. Yes, you do. So this is a patient with an esophageal cancer. So you can imagine what has happened. We have a fluid level in the pleural space with multiple reflections, some compressed lung, abnormal mediastinum. Here's the lateral. You get this complex abnormality. And this is just a really bad case of cancer. There's infiltration in the mediastinal fat. But what we see, where did I pass it already? No, it's down low. Just this ugly looking esophagus. And then you can follow right in here. There's a contained perforation, and that's become fistulous with the pleural space. You can just see it falling right into there, communicating right there. So a esophagopleural fistula from a cancer that's sort of contained rupture that's diffusely infiltrated the mediastinum, and this became all infected and was an empyema. You can see all the bubbles of gas, the hypertrophied extrapleural fat slightly hypertrophied, and then that very angry collapsed lung. So that was pretty dramatic. And then this last case is, we've seen many, many examples, but this one was pretty, and you may be able to pick it up on the radiograph, but there are these fine reticular opacities in the lower lobes that were initially interpreted as an infection, but when going back to I just saved the more recent radiograph, but I mean an older radiograph, but the newer one was interpreted elsewhere as an infection, and on our review we had access to the CT, and you can see that indeed these opacities are chronic, and this is from many years ago. They're calcified or ossified and branching. They're located along septa. Let's see, here's the bone window display, but you can see how dense these are. So this is a nice example of dendriform pulmonary ossification. Now I couldn't find, aspiration is always what I'm thinking about, but there's really nothing that pointed to that. This is a younger man. He's actually 47. You can see very muscular. We see this, so very fit person. And so nothing good to explain it. No fibrosis, no underlying, like I said, aspiration or other chronic lung disease. So I don't know, if he was taking supplements or something. I didn't dig around too much, or something that altered calcium metabolism, or, maybe in the past was doing some stuff and it just sort of doesn't go away. So hard to say.
Is he a weightlifter?
Is he a what?
Is he a weightlifter?
Oh, clearly those pecs. Wouldn't doubt.
Well, the pecs are big, but the rest of his muscles aren't that impressive. What about his diaphragm? Is that hypertrophied?
Those are pretty big shoulder girdle muscles. I don't know, David. That's pretty big for me. I mean, look at the serratus. It's bigger than most people's pecs. He's a weightlifter for sure. His diaphragm looks healthy.
Yeah, it's a little hypertrophied there. Yeah, cool.
Yeah, Jeff, the distribution would fit for aspiration. It does seem to be a little bit more dependent. And we had one that was biopsied that was alveolar ossification. I showed it within the last couple of years because somebody thought it was sarcoid, but it was it was similar, like middle-aged person who had no other history, and it turned out to be what they thought was aspiration.
Yeah. I mean, maybe it was. I didn't have a lot of information on him. He was just a quick visit to the ED kind of patient, so I don't have a lot of records, but we were able to dig up some old imaging. But it's just a nice example to add to our collection.
Very nice.
Okay, guys. Well, thank you. I've got to get on another phone call, so have a good rest of your week, and I'll talk to you next week.
Thanks everyone.
See you guys. Bye.